Thanks very much, Harvey. I don't really recognise myself from the introduction, but that's great. So, yeah, Chris Hancock from Old South Wales, and it's a real pleasure to be back in Sydney. 20 years ago, in 1995, I left having spent a year working in and around as a nurse in various ICUs around Sydney, so it's a great pleasure to be back, and thank you for having me. I have got some pictures of myself in Lycra, to hide mine. This is an example, I think, of the approach that we've taken in the UK, particularly around sepsis, and the idea in Wales in particular of almost that branding, the idea of taking some examples from the commercial sector and applying it to healthcare in terms of campaigns and so on. And what we've done in the UK is that we have, every year we have, well, as you do yourself here, obviously World Sepsis Day, but as part of that we marked that by the Cycle for Sepsis. Proud to say that we were the first team to do that, along with the Scots in the UK. We cycled from the west of England, west of Wales to London, 300 miles, long distance for me. I know it's very little for yourselves from here. But that's a picture of us having arrived in Westminster on the top left, and the picture that you see there on the right is something that we did along the way, which was visiting various EDs, various hospitals along the way, raising awareness, but also raising awareness of the great work that's been going on as well. Because I think a lot of the time we get the perception, particularly from the media, that healthcare is struggling, healthcare is failing to meet the targets and the needs of the people that it serves. And a lot of the time we need to promote the great work that's going on. You'll also see that it provides us with an opportunity to enjoy some of the more recreational side of cycling, particularly the refreshments on the bottom right there. It's useful, and you can go on the website actually, it's useful to look at this just as an example of what we're talking about with Wales. Wales is this little area down here, if you weren't aware of that. I know you may well be from the rugby, but we won't be talking about that this afternoon. So we cycle from over here to London. Wales has a population of around 3 million, and which is probably about the same size as Sydney itself, certainly a lot smaller than New South Wales. Most of the population lives either along the top or the bottom. We have what we think are quite rurally remote areas. What I'm talking about with rurally remote is probably about 2 hours ambulance drive to an ED, as opposed to 2 hours flight to the nearest healthcare facility. But nevertheless, a large part of the centre of Wales isn't very highly populated. We estimate, based on the ICNARC data, the data that comes from intensive care, that sepsis accounts for probably around just short of 5,000 cases in Wales every year. And the deaths probably due to that are around 1,800. Now this is old data, and this is data that's taken from intensive care sources, as is much of the data, certainly in the UK. And we've all long had a feeling that actually that data is misrepresenting the true case. But we haven't really been able to put our finger on how we measure sepsis and its effect in terms of mortality and harm until fairly recently, when we revisited the codes, the ICD-10 codes on sepsis. These two codes, A40 and A41, are particular codes, and I'll go through what they actually mean in a moment. Traditionally, we've tended to not look at the ICD-10 coding because traditionally we have had little confidence in it being particularly accurate. Also, there has in the past, prior to 3 or 4 years ago, been an emphasis on the identification of an organism in the bloodstream before being able to diagnose that this person has septicemia. But times have changed, and we revisited the codes and we did an analysis. So this is all episodes of all the patients, inpatients and admissions through all of Welsh hospitals where sepsis has been recorded as either a primary or secondary diagnosis. So there's obviously a bit of inflation there, but I'll get onto that in a minute. And what we found was that looking at as a whole country, we were able to see that there appeared to have been a reduction in the mortality associated with these two codes from 29% to around 23%, occurring at around April 2013. Translated into numbers of people, because of course that's what's important, that could mean as many as 500 fewer people dying every year for the last 2 years associated with sepsis. But of course, you don't want to jump on all of this and immediately start to publish it. So we've done a little bit more analysis around it, and I'll just share some of that with you. Incidentally, the codes, this is 40 and 41. You'll notice that 419 there, sepsis unspecified organism. That, in the last few years, the unspecified organism is the sepsis that's been diagnosed symptomatically. That, in the UK, certainly in Wales, has risen exponentially. There's far more of that, and I think that that is certainly attributable to the awareness raising and some of the work that we've been doing as part of the Rails programme in terms of making it easier for people to identify sepsis. First of all, we thought, well, is that work actually leading to a rising denominator, a rising incidence against which we've got a sort of relative drop in percentage mortality? Well, that didn't seem to be the case. So the last 4 years, it's been relatively stable at around 10,000 episodes per year in Wales. So that doesn't seem to be a reason or a potential problem. Is it because of episode inflation? So every episode is a consultant that the patient has been under the charge of as they go through their hospital journey. So obviously some patients will have more than one consultant episode. So we looked at and did a further analysis of mortality according to spell. Spell in this case is on death and discharge. So we're looking at just one flashpoint at the end of the patient's stay in hospital. And what we found that there's a consistent relationship between spells and episodes. There's around 2/3 spells to the number of episodes, but that is consistent across the board. And the reduction in mortality remains at around the same. There was also another question of, did these people die of something else? It was being recorded as something else. The two most common infections associated in Wales with sepsis that it could be being coded for is urosepsis and pneumonia. So urine tract infections or pneumonia, respiratory infections. And so we analysed those as well and found that basically the deaths from there, those had slightly dropped rather than risen in comparison. So we're fairly confident that what we've got is a stable denominator, we've got a reduced numerator, therefore less people died. We're fairly confident that for the first time, we're actually able to quantify the effect of what it is that we've been doing in Wales. What happened then at around 2013? We know that correlation doesn't necessarily prove causation, but when you get a change, did anything happen across the country at the same time that may be associated with that change? Well, actually it did. But 3 things happened at the same time, which I'll go into in a little bit more detail. But the first thing is that the National Early Warning Score was introduced and had become embedded in all of the acute hospitals in Wales, in all of the acute areas, including the EDs, by April 2013. We had a standardised sepsis screening tool across all hospitals in Wales, and I'll talk a little bit more about the critical care outreach teams in a minute. But first of all, the National Early Warning Score is actually, I'm just going to in the front of my bag, bottom pocket. I've got loads of little cards in there as well. I can probably display a bit better. So, cumulative score of patients' observations. Each observation carries with it a particular number in that category, depending on how deranged it is from the normal. That's brilliant. Thanks very much. And according to that, all of the 7 categories summed together give you a summative score. In a paper well, I believe the date's 2010, but by Product et al., the original score, which came from VitalPAC views, was evaluated against all existing summative scores plus single trigger scores, and was found to be the best predictor of death within 24 hours of all of them. Now, we at that time had managed to get the consensus across all of the medical directors, nursing directors within each of the health boards that they would go for a single score. So we decided, well, we'll go for the one that's got the most evidence to support it. That way we've got less battles to fight. That way we can just say, look, this is the best that's available, we'll all adopt that, and it's new for everybody. What we didn't do, though, however, which was what the Royal College of Physicians in the UK had asked that everybody do, was to adopt the same chart. They had come up with, the Royal College of Physicians in the UK had come up with a chart at the same time as coming out with news as well. We felt that whereas the new score was evidence-based, the chart itself had very little evidence to support it and didn't actually seem to be based on any human factors type thinking about how easy it was to be used. So instead, we asked each organisation to incorporate news, incorporate escalation in their charts, and incorporate sepsis screening in their charts. But other than that, to develop the charts per organisation. So one chart per organisation, get back together every 3 months or so, everybody shares what's going on, where everybody takes responsibility. And I strongly feel that allowing or enabling the organisations to do that was a strong factor in their acceptance of news and their continued use of it. And so I know that news is embedded because it's become a verb. So rather than a noun, you now hear nurses talking about, oh, so-and-so was newsing at 9, or they were newsing at 3. So once you hear that, it becomes a universal language. It becomes something that everybody understands. So we now have news in place, along with the 3 trigger points. So the 3 demarcations for low, medium, and high risk. 3 is a threat, 6 is sick, 9 is now. So there's a mnemonic attached to it as well. However, observations can be increased at the discretion of the clinical team. Concern about a patient should lead to escalation regardless of the score. So this is about providing a safety net through which people should not fall, not about imposing clinical judgment upon clinicians. At the same time, on the back of the card here, we link in with sepsis. So that if a patient has a new score of 3 or more, then we ask that immediately the action to take is consider sepsis. Has this person got 2 or more service criteria? Is there a suspicion of infection? So you're hopefully making the suspicion of sepsis become a standard operating procedure within ward areas. But also, it's spread, and it's spread because it was seen to be useful use of news. So it's now in place in most of the community hospitals in Wales, and there are quite a lot of community hospitals. It's in use by the ambulance service in Wales. It's the standard and use, and I've got some pictures in a bit to show you them actually using the card. And it's also in place in mental health institutions, in a prison in Cardiff, they're using it. But also in a lot of private care homes. And in the more rural parts of Wales, we have community hospitals with less than 20 beds. We have care homes with over 100 beds. So the care homes are becoming the major providers of early care. And the reason that they find it useful, not because news is the perfect tool for showing deterioration outside of hospital, because it's not. It was developed in acute settings. But what it is it's a communication tool that provides the same language from the person deteriorating in the community through the ambulance service, through the ED, to the rest of the hospital. So suddenly, as of 2013, most of Wales was suddenly talking the same language about how sick people were. The next thing that was allowed us to do was to provide a common screening tool definition for sepsis. So many of you who've dealt with sepsis and acute deterioration will be familiar with the conversations going on at the moment about how easy it is for patients to develop SIRS criteria, so inflammatory responses, syndrome criteria, just running for a bus, for example, or somebody who's got a cough plus those may well be mistaken for having sepsis. So what we were able to do was to provide a sort of cut-off point at the start. So we say if you've got news of 3 or more, then you start to consider the sepsis. So it means that you don't get everybody who's got the SIRS criteria coming forward for evaluation. And so what we're able to do, or were able to do, was say that news of 3 or more, 2 SIRS criteria, plus suspicion of a new infection is a positive screening. And we draw the distinction between saying, what we're trying to do here, we're not trying to provide the perfect diagnostic tool for sepsis. The problem in a lot of cases of people who die from sepsis is not that they get the wrong treatment, it's that they don't get any treatment because nobody's noticed that they're deteriorating. And in Wales, we have a lot of people like Anne-Marie, who, showing off her news card, Anne-Marie, who's a support worker, untrained, who do all the observations. They're the people who interact with the patients on a regular basis. So we don't want Anne-Marie to be able to diagnose with absolute certainty that somebody has sepsis, but we do want her to be able to have a tool to say, this person is positive for sepsis screening, therefore we believe, or I believe, you've got an hour in order to either deliver the full sepsis 6 or to actually decide that they haven't got sepsis, and that's absolutely fine as well. So it's empowering for people to start that process of delivery of sepsis treatment. It provides a time zero against which to measure the delivery of antibiotics and the rest of the sepsis 6. Again, and there is papers published recently which suggest that the delivery of antibiotics within 1 hour is less necessary than we thought it was, less effective, and that 3 hours would be absolutely fine. But again, we're dealing with patients you don't know how long they've been sick for in a lot of cases, either because they're coming through the front door of the ED and you don't know how long they've been sick when they've been outside of the hospital, or they've been sitting on a ward all night and nobody's noticed. So at the moment, we're sticking to the 1 hour target. And the third thing that happened was the introduction or the resurgence of a few critical care outreach teams. This is one here from around 450-bedded hospital, something like that. According to the coding, this particular 450-bedded hospital reduced their mortality from around 41% to around 32% at around the same time as the critical care outreach team managed to get the wards up to around 60% compliance with the delivering of the sepsis 6 within 1 hour. These teams, very far from being the cavalry that turns up just at the last minute, traditionally when we always used to do ALS, ILS, life support training, and that in the past used to concentrate very much upon what you do when you turn up and somebody's dead on the floor and you start to resuscitate them. The model has changed radically since then, and this team is not the cavalry. This team are the people who introduce the education, who encourage the teams, who train the teams to respond, and then feed back to the teams about the success or not of what's happened on the wards. One of the things that they've introduced is the sepsis response bag. We're now, due to infection control issues, we're no longer using bags. We've gone over to boxes, and so the idea, simple human factors thing, is people are more likely to use the kit that they're supposed to use. They're more likely to do the right thing if everything they need is in one place and it's easily to hand. So everything you need to deliver the sepsis 6 interventions, so fluids, oxygen delivery, catheterization if necessary, fluid balance chart. They've got the bottles there for taking cultures and various other blood tests as well. Everything apart from the antibiotics, because we can't have those in a loose container. Everything is present in this bag. And the team that introduced that were able to demonstrate that they had extremely good outcomes 24 hours after delivery of the Sepsis 6 with the bag on the patients who were screening positive for sepsis for use of the bag. The downside of that was that in pretty much all of the cases it was the outreach team coming along and prompting them to use the bag, which actually caused them to use the bag. Now what we want these aids to be is actually permission to act. What we're trying to achieve with people who potentially have less experience, less education, less awareness around sepsis is a perception that it's okay to use this. This is what the organisation expects you to do, is to pick this box or this bag up, take it to the patient and use the contents in it. So we're working with a couple of commercial design companies at the moment to actually say, how can we adapt this so it's a bit more welcoming, it's a bit more user-friendly, that it actually encourages people to use it in the way that it's supposed to be used. So watch this space on that one, I guess. The other thing that the outreach teams have been great at has been in the collection of data around acute deterioration, so that each hospital is able to evaluate to some extent how it deals with its management of acute deterioration and sepsis from the data that the outreach teams collect. The downside of this is that they don't exist everywhere. There's at least 5 hospitals in Wales that don't have any sort of outreach or rapid response team. And most of the teams don't operate 24/7 either. And some of them don't even operate across the whole hospital. So that's one of the things that we need to improve for the future is that spread across the hospitals. But what they've been able to do, and some of what they've been able to do, is to collect, and we've been able to provide a database that provides charts for them, that gives them, well, this is called the MILOR number sometimes. It's basically the percentage favourable outcomes after 24 hours. MILOR is the hospital where it originated. What this looks at is some work, a paper published, I think by Subi, under his name, but I can get the reference. But it looks at 4 positive and 4 negative outcomes 24 hours after a patient's been seen during deterioration, been referred during deterioration. Positive outcomes include, of course, end-of-life pathway, but the correlational negative outcome would be sudden cardiac arrest on the ward. Positive outcome would be still on the ward, lower news score. Negative outcome would be still on the ward, higher or the same news score. So they're pretty much 8 balancing positive and negative outcomes. What this does is it says how many of those patients, or what percentage of the patients that have been referred to the outreach team have had a positive outcome 24 hours later. And you can see that with this particular team, it's around 75%. You can also look at the escalation time. How long does it take to get to intensive care for those patients who need, or higher levels of care for those patients who need higher levels of care. The target as such in Wales is under 4 hours, so we consider that to be a good outcome. If we can escalate in 4 hours. I'm not sure what your equivalent might be. But then, of course, it also gives us a good figure on number of patients who are triggered for sepsis there. So this 450-bedded hospital, you're looking at around, what, 16, 17 patients per month triggering. This is outside the ED as well, so this is in inpatients. So that's probably about the same for most of the hospitals that we've got. And of those patients, what's the percentage compliance with the Sepsis 6 within 1 hour? And you can see it's around 55%, which doesn't sound brilliant until you consider that, you know, even if they go 10 minutes over the 1 hour, they're still non-compliant with the bundle. Even if they don't do one element of the bundle, they're still non-compliant with the bundle. This is It's a very broad way of doing quality improvement. But what's noticeable, even though it's 55%, it was around here. If you look at the sepsis coding mortality that I showed you earlier for this hospital, it was around here that it dropped from that 41% down to about 32%. Once they'd achieved a higher compliance. Personally, I think bundles are great. I'm a big fan of bundles, but I don't think there's a direct correlation necessarily between use of the bundle and quality improvement. I think it's what goes on around the bundle to put it into place, which plays a huge part in bringing about that improvement. And they can also then look at those patients and cross-index with the mortality data from that hospital to say what's our mortality associated with those patients. 30% is probably about normal for a lot of our hospitals. The other advantage of news being a number as opposed to being just a single trigger or multiple triggers is that it allows you to do some quantifying of stuff. But one of the things it allows us to do, and one of the measures that the outreach teams collect, is the median news score in relation to patients who turn out to have sepsis. So this is the news score when the outreach team first turn up. This is the referring news score. And you can see that it's about 7. Now if you remember, 3 is a threat, 6 is sick, 9 is now. 6 is a pretty good chance of somebody dying in the next 24 hours. So what we can say is that even with this highly approachable outreach team, even with the sepsis bags or whatever we've got going there, we still have people waiting too late to refer patients who turn out to have sepsis. And people who wait too late to be referred are the people who die. And that's why mortality remains as it is. We also know something else that's been done in Wales is this size of sepsis in Wales study. This is last year's, where we had only did 4 hospitals. What we were able to do was, I wouldn't say make use of medical students, collaborate with medical students in the collection of 24 hours data on every patient in situ or on admission to 12 of the hospitals in Wales. There's around 19 acute hospitals, so they got a fair few of them. And they use little tablets, and on the tablets they're able to input the data surrounding these patients. That data went back to a server and then was able to be analysed centrally. They used the same screening tool that we used in Wales, and the prevalence, I guess, of sepsis is probably about 2% this year, but the associated mortality is around 35%. They were also able to demonstrate that the delivery of all of the elements and the involvement of critical care was suboptimal as well. So we know that we've still got a long way to go. One of the things that we've started to do is to start to work with clinical microsystems or small teams, really. So small teams of people. So this is on the top right there. This is an ED, again in around probably about 400-bedded hospital. And we've started to work with them on a weekly basis. So really intensive working. We go in and their team and 2 or 3 of us, including the data analysts, we've got absolutely vital data analysts, are there. And we go through this DRIPS mnemonic, if you like. This is the way that we structure the meetings. And the very first thing that we talk about, which is why we need the data analyst there, is the data. So let's not talk about your impressions of what's going on just at the moment. Let's not talk about what's wrong and why you can't do stuff on this particular, and why so-and-so isn't talking to so-and-so, and why it's all far worse than it was 10 years ago. Let's just look at the data. What's the data telling you? How many people screened positive for sepsis in this ED in the last week? Right, numbers there. How many of those the week before? What was your compliance with the sepsis 6 the week before? Right, we've got that data up there. What's the mortality associated with that? Because we've got a 2-week lag on the cross-indexing of mortality with that set of patients within that ED. And what you've got there almost is almost the start of a sort of registry of patients with sepsis. alongside the database earlier. So we get the data up there to be talked about, and then, because we use this highly advanced carbon copy piece of paper here, we're in the 21st century, we haven't got any of our wards using electronic systems at the moment, apart from the ITU. So we've got a sheet of paper, and on it you've got your, down one side, your sepsis screening tools, so what's the news, what's the SIRS criteria, what's the suspicion of infection, time that it starts, and then on the right-hand side you've got the sepsis 6, and then a bit further down you've got the review as well. Carbonated, one set goes in the patient's notes, the other is kept for this meeting. And so all of the members of the team, and we encourage junior members to come in and look at this, are circulated around, and they establish what can be learned from each of those cases of sepsis. So what is the sort of the new score looking at? What are the typical sort of presenting infections that are underlying this? What was our response? What have we fallen down on with this response? Was it actually sepsis? How many false positives are we getting through? You know, are we overdiagnosing sepsis? And so that information is then shared, and based on that, the improvements, what are we going to do differently next week? EDSAs, potentially. And then, vitally important, plot the dots. Let's get this data out there where everybody can see it, because when it's up there, on the wall, on a ward, it's everybody's responsibility. It's not just the responsibility of the sepsis liaison nurse or whoever is supposedly taking that forward. So Sue is again one of the support workers, and she's this week responsible for filling in that data. The mortality data is not on the wall. This is in public areas, so that's on the corridor on the way into the ward. But the sepsis incidents are, and the compliance are as well. And you can see Jade filling it in here. You can see their compliance starting to go up now over the last few weeks. They've been up to around 100% pretty much week on week. But what this does is they can then say, right, the reason our compliance is poor this week is because of this, we need to improve, or well done, you got to 100%. You know, you reward excellent behaviour so that everybody sees the excellent behaviour, and you decide as a team what needs to be improved, and it's all highly visible. And this is in that ED that you saw earlier, and their sepsis 6 compliance. So you know when you start doing work with care bundles and you talk to clinicians, they get offended, don't they, generally, because you're talking to them about very simple stuff. You're saying, you should be doing the observations here, you should be doing. And they go, of course we do. That's what we do. That's our job. Of course we do it every time. And it's only when you actually get people to measure their compliance, their reliability with doing that simple stuff, do they realise that actually we're pretty poor. And this ward, this ED, week on week, was getting, sort of 0%, 0% compliance, 0%. Oh, we're not actually doing this, or we've lost the forms. All of the stuff that is just lost in the general busyness of every day. People realise just why they're not achieving what they should be achieving for patients. And once they do start to comply, and again, it's only around 60%, if that, 55, 60%. But that's their mortality, and that's on an increased number. They've started to spot probably about twice as many patients in the ED as they did when they first started doing this. So they've maintained percentage mortality there around just under 10% probably as a mean there. One of the other things that using the same tools has done is absolutely brilliant, is got the ambulance service involved in some of the areas. So this is Adrian, completely unprompted. He's the ambulance liaison officer, so what he does is he stands in the ED as patients are coming in and sort of directs where they're going to go, and he also has his own caseload as well. He's an extremely busy man, but obviously very, very experienced. But I was just talking to him, he had this around his neck. News tells you how the patient is now, not yesterday. Right? So basically what he's saying is that I don't need to listen to this huge, great list of stuff about every patient that's coming in. Tell me what the news score is. I've got a good idea of how sick they are when they come in. It helps me to allocate where they go. We've also got the app. The app's only available on Apple. I can't download it, I've got an Android phone. We're working on an Android version, apparently. But Andrew uses the app rather than uses the card. So on the way into the hospital, into the ED and the ambulance, they will do a news score from the observations. They will proceed to doing the sepsis screening. And if that's screening positive, they will pre-alert the ED that we've got somebody coming in who's sepsis positive. And then what we found was that, you can't quite see it on here, but this is delivery of the full sepsis 6 within 3 minutes of admission to the ED, which is incredible, isn't it? They're regularly achieving less than 15 minutes for full delivery of the sepsis 6 in this particular ED. This is one ED. You know, this is where they've got it right. So, you know, I wouldn't want to pretend that we've got this across the board. If we did, it would be brilliant, wouldn't it? And we do need it. And this is a bit of work that was done by Paula. She's a paramedic over in West Wales. She just looked at their admissions through their ED over a month. It's a fairly rural ED as well. They found 9% of all of their ambulance transfers were positive for sepsis screening criteria. 1% were in full-blown septic shock. Not one of those 1% survived for more than 48 hours on admission to hospital. So in the UK, we're now talking about red flag sepsis and refining that definition of what sepsis is in the sepsis screening. And this is one of the responses. This is by the UK Sepsis Trust. You can see what they've basically done is they've looked at SIRS criteria that are more deranged than what we would normally do here. And they've called that red flag. Now, I think that's fine if you've got an ambulance crew who are going to pre-treat with antibiotics as well as pre-alert. So if you've got an ambulance crew saying, yes, we're going to diagnose this as sepsis and we're going to deliver the treatment prior to the hospital, I think you need to have that sort of sense of security about what you're doing. But personally, if what you're doing is you're expecting them to pre-alert that they suspect somebody has sepsis and it needs to be identified again once they come into the ED, my discussion with the ambulance trust is that you probably don't need to go through all these levels. You don't need a complicated tool like this. Keep it simple. This is our most remote area. This is Powys. It's got 10 community hospitals, a lot of these care centres, care homes as well. And they took a different approach. They said, let's evaluate news. So they're using news, they're using the news score, but they said, well, obviously the actual trigger points are going to mean something different for us. Our patient population is very different. So they did a huge amount of work in terms of evaluation. This is looking at their existing score versus the new score here. And we encouraged all of the hospitals to do this prior to taking up news, just to establish for themselves that news was actually better at spotting the sick people than their existing score. But in Powys, they went a step further and they followed a few patients through, looking at what actually was a sick person. So in these community hospitals, they find that actually 3 and possibly 4 on news is not a good predictor of patients that are going to deteriorate. In fact, a lot of their patients, elderly, frail patients, sitting in the community hospitals, are probably quite happy sitting there at a news of 3 or 4, and may even well be discharged on a 3 or 4. That's fine. But what they did find was that news, even in a community hospital, once they hit 5 and then 6, that person was sick, and that's when they needed to actually call out for some help and get some help in. And that's what it's been able to do for them. And that's an example of the several iterations that they went through again in the same place of redesigning the form. Part of that was to bring people in. I'll just brush on the fact that we've got maternity model as well in the community where they use their own scoring system. And just move on to
couple of things that we've done together. This is the All Wales microbiome induced severe sepsis, so antibiotic guidelines for sepsis across Wales. About half of the hospitals are probably using this. I'm sure many of you have experienced the sort of pushback you get, but it's certainly something that's developing and is absolutely necessary, I think, in terms of antibiotic stewardship. And this is a patient safety alert stating that sepsis is a priority for NHS Wales in the coming years or so. So I think we're on firmer footing in terms of where we go next. So just in summary, standardise what can be standardised. News and sepsis screening tool are good enough. It doesn't need to be perfect. Make it easier to do the right thing. At the moment, we're identifying and transferring to secondary care with pre-alert rather than treating. But in the future, we'll be looking to treat. And trying to achieve reliability with doing the simple things for every patient, every time. And most importantly, make sure you celebrate success. Sepsis bake-off. Last year's winner on the right, chest x-ray cake. And today, this year's winner on the left. They obviously take it hugely seriously. So thank you very much for your time.